Welcome to today's episode of the Zedu Coaching Corner. I'm your host, Suean. If you haven't yet done so, feel free to subscribe to our YouTube channel. And for all the ultrasound educators out there, feel free to sign up to our Facebook community, the POCUS Educator and Seed Support Network. I want to let you know that this session is being recorded and it will be available on our website in the next few days, along with all of our previous episodes of the Coaching Corner. You can find that under the resource tab on the homepage at ultrasoundtraining.com.au. Now, feel free to ask me questions, but if you'd rather ask them offline, save them up to the end and we can edit them out or just turn the recording off. So just let me know and we can come back to them at the end of the session. Can I get you all now to just make sure your microphones are on mute and we'll get started. So tonight's topic is how to scan for early pregnancy loss. When a woman presents with symptoms of signs of pain and bleeding in early pregnancy, there are 5 possible outcomes. They could have a normal intrauterine pregnancy. They could have an ectopic pregnancy. They could have a failed intrauterine pregnancy. It might be indeterminate insofar as it's a bit soon to be able to give a definitive answer. Or there might be other causes such as a molar pregnancy that might be causing their pain and bleeding. And ultrasound is really useful to aid in the differential diagnosis. So at this point, unless there's a life-threatening situation that dictates immediate management, a key question you need to ask yourself is there a chance of a viable pregnancy? Now, this question is central to how the patient is managed. Are we dealing with an intrauterine pregnancy of uncertain viability or a pregnancy of an unknown location? So for a woman with an intrauterine pregnancy of uncertain viability, the answer to this question is central in deciding whether we're going to proceed with evacuation of the uterus or not. And for a woman with a pregnancy of an unknown location, the answer plays an important role in deciding whether to initiate treatment for a suspected ectopic pregnancy. And so what we're going to cover tonight, I'm just going to go through the normal developmental milestones of early intrauterine pregnancy development. We're going to look at those pregnancy failure criteria. I'm going to go over how to measure the mean sac diameter and the crown rump length, how we use the criteria to determine whether this pregnancy has failed, and then some of the things that we might say to our patient in that counselling session immediately as we finish the scan. So when there is a gestation that's 7 to 8 plus weeks, it's very easy to determine the viability because we see a little embryo and we see a heartbeat, and so it's an easy answer. The problem is that our patients often present much sooner than this. And increasingly, women are very aware that they are pregnant a lot sooner, especially since, when we look back 20 years ago, those pregnancy tests are getting much more sensitive now. A home urine pregnancy test can return a positive result in as little as 10 days after conception. And so that's even before their last menstrual period is expected. And we are not going to see any signs of an intrauterine pregnancy at this stage. So it doesn't help us in that positive pregnancy test doesn't mean that, yes, we're going to definitively see it, but our patients' expectations are they're pregnant and they want an answer. So let's start at the beginning. If our patient reports that their last period was 4 weeks ago, we should expect to be seeing a thickened endometrium that's a secretory phase endometrium. And the endometrial outline is just here. Endometrium is thickened in anticipation of an embryo implanting. So if we see someone who has supposedly is expecting their period and the lining of their uterus is thin, then we start to think that things aren't progressing as we would expect. The very first signs of pregnancy that we can see is a small cystic space. And this cystic space or fluid collection represents a very early gestational sac. Now, they talk about the double decidual sac sign. This consists of the decidua parietalis, which is the lining of the uterine cavity, and the decidua capsularis, which is the lining of the gestational sac. And those two layers are seen as two concentric rings surrounding an anechoic gestational sac, or a black cystic space. In early pregnancy, if the double decidual sac sign is present, it's highly suggestive that there is an intrauterine fluid collection and that it's probably an intrauterine pregnancy. But we only see that double decidual sac sign in 50 to 60% of cases. So if we're not seeing the double decidual sac sign, the absence of that sign doesn't confirm a pseudogestational sac of ectopic pregnancy. We need to wait and see what's going to happen. The gestational sac should be seen eccentric to the endometrial canal. So the embryo embeds itself into the endometrial tissue to establish the blood supply, which will later on to become the placenta. Now, when we see something that we're not expecting, like on the other hand, we have a fluid collection here that doesn't look like an intrauterine pregnancy. So you can also have a pseudosac associated with ectopic pregnancy, and there are a number of mechanisms, but it's most likely thought to be a little bit of blood coming down the fallopian tubes and collecting in the endometrial cavity. And we look at that little cystic space, and if it looks spindle shape here or teardrop shape without that double decidual sign, it's likely that it might be a pseudosac. The other thing we're looking for is its position in the endometrium. If it's centrally located in the canal, I'm much more suspicious that this is a pseudosac associated with ectopic pregnancy rather than an intrauterine pregnancy. Now, if we compare that with the image over here, where you can see a very round cystic space and the decidual cast or the double decidual sac sign, which is just off to the side and eccentrically located in the endometrium, this is much more consistent with an intrauterine gestational sac. So the next structure that we can see is the yolk sac, which usually appears as a circular, thick-walled echogenic structure with an anechoic center within the gestational sac. The yolk sac is the structure that provides nutrition to the developing embryo until the placenta has developed and takes over. Now, in transvaginal ultrasound, the yolk sac can be seen from about 5 weeks, 4 days and onwards. It's positioned between the chorion and the amniotic membrane, and we can see that yolk sac up until about 12 to 13 weeks gestation, by which stage the chorion and the amnion have grown so large and are almost fused, and so it makes it difficult to see the yolk sac after that. Apparently it's still there though. So in order to conclusively determine an intrauterine gestation, we must see a yolk sac. So that's the next milestone in a normal developing pregnancy. The presence of that yolk sac defines that as an intrauterine gestational sac rather than the pseudosac of ectopic pregnancy that we saw on the previous slide. Now, after that, we get development of the embryo. And so at 6 weeks, mostly it's the heart forming. There's some very primitive facial and spinal structures there, but mostly it's the heart forming. And so what we see is this tiny little blip. And because most of it is heart, all we see is like 2 little lines flickering on the ultrasound. Now, in these images, you can see it looks like the diamond here of a diamond ring. And the ring part here is the yolk sac, and the diamond bit is the small developing 2 or 3 millimeter embryo. After that, as baby gets bigger, it's much easier to see and record a heartbeat. And this is what confirms viability of the pregnancy. And so the other thing about the heartbeat is in that early phase of development, so in about week 6, it's not unusual for the heartbeat to be a little slow. And we can see that on this image on the right here. If you look in here, there's a very, very faint heartbeat. Now, often that can be maybe less than 100 beats a minute. And in week 6, I'm not going to be too worried about that because the circulation is just getting established. But from week 7 and onwards, we're expecting the heart rate to be between 120 and 180 beats per minute. So if you were concerned about this pregnancy, it's not unreasonable to follow up with a scan a week later to make sure that everything is progressing normally. Now, to confirm a viable intrauterine pregnancy, we need to see 3 distinct structures. The intrauterine gestational sac, we need to see the crown rump length, a yolk sac, and we also look for the fetal heartbeat. And it's only when we see those structures that we can confirm a viable intrauterine pregnancy. Now that leads us on to how do we determine whether this pregnancy has failed. Now the pregnancy failure criteria are based on a transvaginal ultrasound. Now I've reviewed a lot of different protocols from around the world, the ASM protocols, ISUOG, AIUM. All of these protocols agree on the measurement numbers, but a lot of them vary in the nuance of how you follow up the pregnancy, how many days you wait, etc. So there may be some local guidelines that you can look at to make sure you're doing the right thing for your area. So on transvaginal ultrasound, we're looking for a crown rump length that is bigger than or equal to 7 millimeters with no fetal heartbeat observed over 30 seconds or more of scanning. If the intrauterine mean sac diameter is bigger than or equal to 25 millimeters with no fetal pole or no yolk sac, we can say that this pregnancy has failed. And the other criteria is a failure of interval growth on a follow-up or a repeat scan. Now, the important thing about these pregnancy failure criteria is that the measurements are based on images acquired in a transvaginal scan. And the reason why they're based on transvaginal scanning is that we get much better detail of the early structures of pregnancy transvaginally. The probe has a higher frequency, so better resolution, and we're putting the probe right up against the anatomy, so we get much, much clearer pictures. Those same threshold criteria do not apply on a transabdominal scan. The findings might be suggestive of a failed pregnancy, but we can only conclusively say that the pregnancy has failed after a transvaginal scan and the pregnancy meeting those criteria. So typically we see the structures of early pregnancy about a week sooner on a transvaginal scan rather than the transabdominal scan. And in patients with increased body habitus or even a retroverted uterus, it might be very difficult to see those structures of early pregnancy until the patient's 8 or 9 weeks pregnant. And so the problem with these pregnancy failure criteria is that there is this grey zone or this normal period of time that as the gestation is growing, we can't conclusively say one way or the other whether it's a definitive intrauterine pregnancy that's viable or whether the pregnancy has failed. Now, the problem with that is that's very difficult to communicate to our patients. And so as we're scanning in those early weeks between 6 to 8 weeks pregnant, we either have a very clear live intrauterine pregnancy, so it exceeds the criteria and we have a fetal heartbeat seen, or we have a clearly failed pregnancy where the mean sac diameter is bigger than 25 millimeters and we don't see a fetal pole or a yolk sac. And if we see a crown rump length and it's larger than 7 millimeters and we don't see a heartbeat, we can conclusively say that the pregnancy has failed. But that leaves us with this grey zone where we have an indeterminate finding. And that's when our mean sac diameter is less than 25 millimeters and the crown rump length is less than 7 millimeters. Ultimately, what we have to do is just wait for the pregnancy to develop. And as gestational age increases, it makes it much easier to have a definitive diagnosis of an intrauterine pregnancy or a failed pregnancy. Now, the problem with this grey zone, very few women know when they actually conceived versus when their last period was. So this means that their dates and what we can see on the ultrasound might be a little off. They might be further along than they thought or not as far as they thought. They may have ovulated very early or very late. And so there is a normal physiological period that we cannot categorically say one way or the other what's happening. The problem in communicating that to an anxious patient is they want an answer now, and they're used to getting answers now in their life. They can just look up Google and get an answer to any question that they want. Where, I don't know, I've been pregnant, you're a little bit impatient to know that everything is progressing normally. So let's talk about that grey zone. That's the period between 5 to 7 weeks on a transvaginal ultrasound, potentially 8+ weeks on a transabdominal ultrasound, that we can't conclusively say. So we haven't met those threshold criteria. The important thing for us to remember when we're scanning our patient and deciding when we're doing a rescan to be able to determine whether this has failed or not is how far along are we now and how much time needs to elapse before we will be able to have a conclusive result. We don't want to be in the situation where we say, oh, come back in 2 days and the mean sac diameter is 13 millimeters, and that mean sac diameter will grow by about 1 millimeter per day. So if they come back in 2 days' time, we're still not going to be able to conclusively say whether it's failed or not. So we have to allow enough time in the intervening period for the baby and those structures to develop so that we're not just doing lots of rescans, because that can cause a lot more anxiety for the patient. And so we've put together this simplified version or decision flow chart, if you like, to help with this. And as I mentioned, your local protocols are likely to be much more detailed than this, with recommendations exactly for when you should and shouldn't follow up. But we've simplified it here from the point of view of those key structures that we're looking at. How do we know whether we need to rescan or not? And these pregnancy failure criteria follow the way that I approach my ultrasound exam in early pregnancy. I start with a wide lens, looking at, is there any free fluid in the pouch of Douglas, which increases my suspicion of an ectopic pregnancy or not. Then I bring my focus in and focus on the uterus. Can I see anything in the uterus? Can I see an intrauterine gestational sac? Now, if I can't see an intrauterine gestational sac, then we progress on and do an EFAR scan, looking for signs of free fluid in the pelvis, and look at the right upper quadrant for signs of free fluid in the right upper quadrant. It could be a pregnancy of unknown location. It could be a pregnancy of unknown viability. Now, if I do see an intrauterine sac, the next thing, focus on the uterus to confirm that. Then I focus on the gestational sac, and we're looking to see, is there an embryo? Now, if we can see an embryo and it does have a fetal heartbeat, then it's a live intrauterine pregnancy. But if we see an embryo and there's no fetal heartbeat, our next question is, how big is the crown rump length? Now, if the crown rump length measures more than 7 millimeters, then we can categorically say that the pregnancy has failed. But if the crown rump length is less than 7 millimeters, this is a pregnancy of unknown viability, and we need to rescan in a week or so. Now, if we did not see an embryo, our next question is, do we see a yolk sac? And so if we do see a yolk sac, that then classifies this as an intrauterine pregnancy. So we can confirm an intrauterine pregnancy, but we can't confirm whether it's viable or not, because it might just be too soon. And so depending on the sizes of everything, we might scan in a week's time. If I don't see a yolk sac, then my question is, how big is the mean sac diameter? Now, if the mean sac diameter is more than 25 millimeters, I can conclude that there is a failed pregnancy, or this is a pregnancy loss. But if it's less than that threshold value of 25 millimeters, then we're looking at a pregnancy of unknown viability. And depending on how big that sac is, we might rescan in a week or 2 weeks. And so that means that when we need to determine whether the pregnancy has failed, we have to be able to take a good mean sac diameter measurement. The mean sac diameter measurement, you measure the length of the gestational sac, the depth and the width, and you add them together and divide by 3. So the mean sac diameter is a useful measurement to date the pregnancy before we see a fetal pole. If we see a fetal pole, then we use a crown rump length, and crown rump length is the most accurate dating of the pregnancy out of all the biometry measurements that we do across the pregnancy. Now, if the mean sac will grow by about 1 millimeter per day, and so you can use that rule of thumb to figure out how long it is that you should be waiting to rescan the patient. So for example, if your mean sac diameter was 21 millimeters, well, in a week's time, it should be 28 millimeters. And so it would then fall into that conclusive diagnostic category of a failed pregnancy if nothing had developed. But if we had a mean sac diameter of 12 millimeters, for example, then we may need to suggest a rescan in 2 weeks' time because it grows by 1 millimeter per day. So in 2 weeks' time, we'd expect that mean sac diameter to be 26 millimeters, and so then it would be conclusive. And so when we measure the mean sac diameter, the way I've talked to some of my colleagues here in the office, and we all do it slightly differently, but this is the way I teach it, because often your machine, some of the machines will come up with you doing 2 measurements on your first view, and then it automatically toggles over to the third view. So I tend to get a sagittal view of the uterus and scan through the uterus to find the biggest portion of the gestational sac. At this point, I measure the length of the gestational sac, and at 90 degrees to that, I measure the height of the gestational sac. And so then when we go into the transverse plane, we measure the width of the gestational sac. Now, it's possible that you do the width and the depth here, in which case you would only do the length in the long. We don't want to measure the depth in both planes, because the depth is the depth no matter which way you're holding your probe. So we need to make sure that we have got 3 orthogonal measurements to get a mean sac diameter. When the embryo is visible, we don't have to worry about it at all because we'll measure the crown rump length. Now, the pitfalls of measuring gestational sac are many. The calculations package on your machine only goes up to about 8 or 9 weeks, depending on your system. And after that, it'll be out of range. So once we see the crown rump length, don't worry about measuring gestational sac. Make sure you get a good measure of crown rump length. Now, as you can see in this gestation, which measured about 8 weeks, it's difficult to know where do we place our cursors. So in this longitudinal plane here, do I measure the depth here or the depth here? Now, it's almost double. And that can greatly influence whether when the margin is maybe 24 millimeters or 26 millimeters is diagnostic, this would make a big difference. In the width, do I measure here or do I measure here? And again, the combination of those measurements means that it's potential for us is to have a grossly underestimated or overestimated gestational sac measurement. And so that's why we're using gestational sac up until about 7 weeks, because up until about 7 weeks, it's quite round. And so it should be almost the same distance in all directions. But then it starts to occupy more space in the uterus and it's not so round anymore. It's certainly curved and smooth walled, but it's not as round. And so it's hard to know where to put our cursors. Here's an example as we scan through. And it depends where I pause my image. Now, on this first image here, I have measured just about here and got a measurement of 6 weeks, 4 days. And then as we scan through, we find a wider measurement, which is here, and it ended up being 7 weeks, 4 days. So it's really important for you to scan from lateral border to lateral border to find your widest point, and from inferior border to superior border, again, to find the biggest sac diameter. Here's an example of core caliper placement. So you can see in this image on both views, we're a little bit undercooked here and a little bit undercooked on the length. Those calipers should be on the edge of the black where the black meets the white. In the transverse view here, again, these calipers are slightly underdone. And so what that's going to do is underestimate the gestational sac by 2 or 3 millimeters. Now, if we're at a true gestational sac measurement of 25 millimetres and we've underestimated it here, we're potentially causing our patient a week of anxiety when we might be able to have a conclusive answer for them today. But in the end, if you're unsure, it's easier to order a rescan than it is to cause an intervention that might be doing something to an otherwise normal pregnancy. So let's look at some examples of how these criteria apply at the limits here. Let's say that this gestational sac measured, the mean sac diameter was 26 millimetres. And as you see, as we scan through, I can see no sign of a fetal pole and no sign of a yolk sac. So if the mean sac diameter is 26 millimetres, we clearly exceed this threshold criteria. The mean sac diameter should be more than 25 millimetres, and so we can categorically say that this is a pregnancy loss. If that same mean sac diameter came back as 24 millimetres and we don't see a fetal pole or a yolk sac, then we could repeat the scan in a week's time. And in a week's time, if nothing's changed, then we can say that there's a pregnancy failure. But if in a week's time we start to see a yolk sac and a crown rump length, well, then we're getting some sort of conclusive result. So remember, the gestational sac grows by about 1 millimetre per day in early pregnancy. And so the repeat scan should show growth commensurate with how much time you've left. So we need to be careful to make sure enough time has elapsed so that when we rescan, that we are getting an answer. In the meantime, you could do beta HCG and see if they're tracking normally as well. So on this instance where the mean sac diameter is 24 millimetres, we can say that this is a pregnancy of unknown viability and we need to rescan it. The criteria for diagnosing non-viability are quite stringent, so they're absolute cutoff values, and they're quite conservative to make sure that we reduce the risk of inadvertent harm to a potentially normal pregnancy. Now let's say we've got the same gestational sac, but this time it only measures 11 millimetres and we don't see a yolk sac or a fetal pole. Now at 11 millimetres, that could in fact be a normally progressing intrauterine pregnancy, but we'd have to wait 14 days at least before we can go over that threshold to be able to categorically say which way this is going. The gestational sac, again, growing 1 millimetre a day, if we're measuring again in 14 days, it should then be 25 millimetres, and we should start to see those structures of early pregnancy, the yolk sac and the crown rump length. So this is a pregnancy of unknown viability, rescan in 14 days. Now, for those of you working in the MTOP space, if we were to scan this seemingly intrauterine gestation, it's got a double decidual reaction here, but I can't see a yolk sac and I can't see a fetal pole. Now, by the rules that apply to MTOP, this hasn't been confirmed as an intrauterine pregnancy. We'll have to wait a few days to see the development of the yolk sac. And it's only once we identify the yolk sac that we can conclude that this is definitively an intrauterine pregnancy. So again, this is a pregnancy of unknown location and a rescan is warranted. So depending on what the ultimate goal is, if you've got an ongoing pregnancy that people are happy with and are keeping, then we want to wait until there is a definitive answer. If we're looking at pregnancy management options, we just need to confirm that it's in the uterus and that it's not an ectopic pregnancy. So we only have to wait until the yolk sac is visible to be able to call that. The other critical measurement that weighs into establishing the viability is the crown rump length. Now, this is the most accurate estimation of gestational age out of all the biometric measurements that we take during pregnancy. It's accurate to within plus or minus 5 days. The crown rump length is the longest straight line length of the embryo without the yolk sac in the true sagittal position. Now, later on in pregnancy, we need to try to get the fetus in a neutral position with clear margins. And I always take at least 2 to 3 measurements so I get a new image 3 times and measure on each time I require a new image to make sure that my inter-observer error is minimized as much as possible. The trouble with the crown rump length, it's one of the most difficult measurements we do out of everything ultrasound I teach, I think. And so what we're looking for in the crown rump length is a true sagittal section of baby. Now, it doesn't matter if it's looking up or looking down. We're looking to have a section of baby where the slice divides baby into left and right halves. We're not looking at the coronal plane, which divides baby into anterior and posterior. And so how do you tell the difference? When we're true sagittal, we should be able to see a profile picture. When we're coronal, we kind of see the front and back of baby. So if you're in the coronal plane, you've got to move your probe in an arc by sweeping and fanning the probe to come 90 degrees to the baby so that we get a sagittal section of bub. Now, here are some examples of a crown rump length at 5 weeks, 5 days. Here is 6 weeks, 4 days. Notice that the yolk sac is not included in that measurement. You don't want to measure this way. And the tricky thing here is sometimes it can look like the yolk sac is like a head because it's round. So you don't want to confuse the yolk sac as the baby's head. 7 weeks, 5 days, there's a little bit more substance to baby. It's much easier to see the fetal heartbeat at this stage. At 8 weeks, we start to see limb paddles. Now, in this view here, you can also see the amnion, that very thin, curvy line. It's a very thin membrane, so we only see it when we're exactly perpendicular to it. Here's an example at 9 weeks, and you can start to see little limb paddles here, the yolk sac up here. And 10 weeks, we're at the end of the embryological period. So all the structures are in place now. They've just got to grow. And the tricky thing here is getting a true midline sagittal measurement. And we measure from the top of baby's head to the bottom of baby's rump. As I was just explaining, it can be very easy to mistake this yolk sac as baby's head. And so if we were to measure the yolk sac and the crown rump length here, we're actually increasing the crown rump length by about 30%. Yeah, not such a big deal if we can confirm the viability. But the problem is that week later on down the pregnancy can have a big impact on how that pregnancy is managed. So when we measure crown rump length in first trimester, it's really important to get the most accurate result because that sets up the management of the pregnancy. So what do we do when we're sitting right on those margins? Now, this little crown rump length was 6.9 millimeters. And we couldn't see a fetal heartbeat. And so according to those pregnancy failure criteria, it hasn't cleared the 7 millimeters mark. And the way I remember this is if it's 7 millimeters, no heartbeat, it's gone to heaven. So on this one, it sits right on that threshold value, just under the 7 millimeters. So this is pregnancy of unknown viability. We need to rescan in a few days' time. If in any doubt, if you're not sure what's going on, order a rescan. Better to err on the side of conservative than to intervene and potentially disrupt a normal pregnancy. So when we're scanning in early pregnancy, it's quite an emotionally charged environment one way or the other. This is either good news or it's bad news for the patient. And so we find ourselves the bearer of those good tidings or bad tidings. But the problem is, how do we communicate the bad news, or how do we communicate that grey zone period? And so what I want you to think about before you start speaking, as the patient is coming in the room, I tend to set myself up with an exit strategy. So I will say to the patient, I might not get all the information that we need today, especially if they're at that 6 weeks mark. Before they lie down and before the probe goes on the tummy, I already sort of prepare them. If we're expecting it to be 6 weeks, I may not have an answer for you today. That's because I need to be able, that starts that conversation if we're in that grey zone and we can't get the answer, or it helps me explain why I need to do a transvaginal scan. And so before you start speaking, once you've scanned the patient, you just need to make sure you've done a very thorough scan and you have all the information that you need. And I we'll reiterate that point, because a lot of the time we go in, we see baby, we see a heartbeat, we can get focused on the heartbeat, and oh, it's exciting, it's good news. And then as you're scanning, you realize that heartbeat is on a fetus that's not sitting in the uterus. So before you start talking, just take a moment, make sure you do a thorough scan going from lateral border to lateral border, inferior to superior, and make sure you start to think about, well, what are we going to say? I also say to my patients, to buy myself time, I say, I'm going to just have a look at your anatomy first before we look at bub. I'm trying to just buy a little bit of time without the pressure of that anxious patient wanting an answer. Then ask yourself, what am I seeing? What am I going to say? And do I have enough evidence to make this call? And if you don't know, then it's a rescan. So what are you seeing? What are you going to say? Do you have enough evidence to make the call? And then you're going to take a big breath. Now, this is as much for you as for the patient, because it's quite challenging to deliver bad news to someone who doesn't want that bad news. But that big breath also signposts to your patient with your body language that maybe things are not quite as expected. And so in the case of bad news, you might start with the news isn't good to help signal that. I know I personally have got caught out by being so poker-faced and not having my body language say anything. So it was like they got smacked in the chops with it even more, because nothing about what I had said or done had left me any opening to start that conversation. And so it's important that our body language communicates as much as anything that maybe it's not good. So you can use your body language, but also just be aware that your body language will communicate. So if you get on and you're scanning and your face falls and you're not quite ready, the questions are going to come from your patient really quickly. So just be mindful, your body language will tell a story as you're conducting these scans. Now, in the case of bad news, here's some things that you might be able to say. And everyone's got their own version here, but here are some things you could try. I'm struggling to see what I need to see. Now, then you can ask your patient, would you like to see what I'm seeing, or would you like to see as I explain what I'm seeing? And this gives them some control over what's happening to them. Some patients need to see and some patients don't want to see. And so the next thing we do is go on to explain what we would like to see at this stage of the pregnancy is, but what we are seeing is something different. And you explain what that is depending on where you are in the pregnancy. And lastly, now they're probably in shock, and so it's really important for you to give them a what happens next. When it's in the grey zone, some things that you might say, what I hope to see is, what I am seeing is, and what we need is time for the pregnancy to grow. Now, often this is quite hard to communicate to someone who's impatient to be pregnant and to know. So we just need to reassure them we need some time before we can make a conclusive answer. And I suggest a rescan in so many days. So to revisit our scan approach, we focus outside the uterus, and that helps us determine, are we seeing any signs of ectopic pregnancy? Can we see corpus luteum? All those big picture signs first. So we're looking for free fluid. I then focus on the uterus, and this is where we're trying to determine, is there an intrauterine gestational sac? Then we focus on the gestation for those structures of early pregnancy. A yolk sac confirms this as an intrauterine gestation. Then we look at the embryo to see if we can see that it's viable. And lastly, when we look at the embryo, we're looking for a heartbeat, and we measure the crown rump length to establish dates and to establish viability. And so the 4 possible outcomes are that this is a failed pregnancy. So the mean sac diameter is bigger than 25 millimeters and there's no yolk sac or fetal pole. Or the crown rump length is greater than 7 millimeters and there's no fetal heartbeat. Might be a pregnancy of unknown location, so it might just be, we can't confirm that this is an intrauterine pregnancy. It could be a pseudosac, or it could be a very, very early gestation. So our mean sac diameter is less than 25 millimeters, and we're probably not going to see a crown rump length at this stage. It might be a pregnancy of unknown viability. So this means that our crown rump length doesn't quite meet those threshold criteria. So we can see the embryo, but we can't see the heartbeat. Or lastly, it could be a live intrauterine pregnancy. And by this, the gestational sac is bigger than 25 millimeters, the crown rump length is bigger than 7 millimeters, and we see a heartbeat. So that's what I've got for you for today's episode. If you found this episode useful and helpful in any way, feel free to refer your friends and colleagues to the resources section on our webpage at ultrasoundtraining.com.au, and feel free to subscribe to our YouTube channel. We have an upcoming Train the Trainer program in November for any of you wanting to improve your teaching skills. And you can also check out at our website our various array of different ultrasound courses. We also do one-on-one scanning and coaching. So feel free to check us out and get in touch if you have any questions. And here's where I throw over to the audience to see if anyone has any questions or comments.
Thanks, Suean. Steve Hall here. That was very, very useful, very reassuring. In emergency, we see pregnant females anywhere from 5 weeks to 10 to 12 weeks. Some have had a 6-week scan, some haven't. Some present at 10 weeks with spotting, bleeding, abdominal pain. And it's really, really useful to be able to provide some, I guess, insight, reassurance, answer a clinical question about where the woman currently is in her transitional progress. And tonight's presentation has been very useful to assist, particularly around the language to use, around this is what I'm seeing, this is what I expect to see. Very challenging, very difficult situation before a formal ultrasound, and very useful in the emergency context. So thank you.
The thing about, I find how to have those conversations quite challenging. And when I was studying, I'd hardly done any pregnancy, and on the first day at a new job, I had 4 miscarriages in a row, and I pretty much went home feeling like the Grim Reaper that day. But and I was very distressed, and part of that was I just didn't know what to say, and so I went through this learning process where I go in with my radiologists, and there were a lot of them that used to break that news. So I had a secret code on my TV that they could come in and help straight away. But and I listened to how other people said that. And over time, like I've given you some ideas today, that's not the only way you can, but it's useful to have some standard phrases up your sleeve to begin the conversation. Sometimes that goes really, really well. Sometimes you find that you have to, for someone saying, this is what I expect to see and this is what I'm seeing, and they get it. Other times you have to say, unfortunately, that means that the baby has died. And your language will change depending on your patient as well, and where they're at. So, for some patients who are not keen on being pregnant, it might be that I use the word fetus rather than baby. But for most of our patients, I'm using the word baby because whether this has actually developed into a baby or not, they think it's baby and they're attached to baby. So, like I said, I think it's useful to have some standard phrases up your sleeve and some strategies to get help. So, what I suggest to my student sonographers, have an exit plan going into the room, and you're preparing your patient. I'm a student, I'm learning, I'm going to get my supervisor to check this, so that the supervisor checking it is part of a normal procedure. Because if you haven't sort of prefaced it before you start scanning with that, then you're getting your supervisor signals bad news for that patient, whether you like it or intend it to or not. And so in the emergency room, if you're not sure, you would start that conversation with, on our point of care machines in the emergency room, they're not as fancy as the ones around radiology. If I'm not sure of what I'm seeing today, I'm going to refer you for a formal scan. So you've got an out if you're unsure of what you're seeing. And it's really important to go into that scan with an exit plan. Otherwise, you can get yourself tangled up in all sorts of mess. Does anyone else have any questions or comments? thank you all for joining me tonight. I hope that's been useful, and hopefully we see you next month. If you have any topics that you'd like me to cover, feel free to shoot me some ideas. Otherwise, tune in for whatever I come up with. Thanks so much for joining me. I appreciate that you have joined me tonight. So good luck with your scanning.